morning, everybody. My name is Eric Lowe. I'm the moderator for this webinar today that's been hosted by Myeloma 360. So a very warm welcome to everybody. The topic for today's discussion is expert recommendations and patient perspectives for treating relapsed and refractory multiple myeloma. We're very lucky today. We've got a very distinguished, esteemed, and well-respected faculty. I don't think they need much of an introduction, but we've got Dr. Rafael Fonseca from the Mayo Clinic in Phoenix, Arizona. You're very welcome, Rafael. We've got Jack Aiello, who's a very famous patient advocate and long-term myeloma survivor. So you're also very welcome, Jack. And Dr. James Berenson, who's a founder and president of the Institute for Myeloma and Bone Cancer Research in West Hollywood. That sounds lovely address, so you're very welcome as well, Dr. Berenson, and it's good to see all three of you, and thank you for taking the time to join us today. This is our agenda for today. We've done the short introductions. Dr. Fonseca is going to talk about current management in relapsed refractory multiple myeloma. Then really importantly, we're going to hear from Jack and the kind of patient perspectives and his perspective on treatment options. And I think, as you will see from Dr. Fonseca's presentation, there's a whole plethora of treatments, which I'm sure makes it challenging for doctors and patients alike to pick between available options in what is a very heterogeneous disease. And then finally, we'll go to Dr. Berenson, who will look to the future and give us an overview of new promising treatments in the pipeline. Most importantly, we're going to try and make sure that the speakers keep to time, because the most important thing in any webinar is the ability to ask questions. And the most frustrating thing for the audience is not to have their questions answered. So we're going to do our very best to kind of burn through the slides and make sure we can answer as many of the audience questions as possible. So there aren't many housekeeping notes, you'll be pleased to know, and hopefully everybody's very familiar now with the online format for these types of meetings. There will be a Q&A window that you can see. You can click on the Q&A icon, which I believe is at the top left of your screen, and ask your questions in the panel. And as moderator, I will select questions and I will direct these to the appropriate speaker or more than one speaker. And for, I think, simple yes, no questions, we may be able to answer questions live by replying to your question as well. If there's any questions that we don't get answered during the webinar, and we have your contact details, we will get one of our faculty to answer the questions for you, and we'll return that via email within the coming days. So you can send your questions anonymously, but it would be really helpful if you would prefer, or you're happy to, is just to give your name and institution. So without further ado, I will pass over to Dr. Fonseca for his talk on current management, relapsed refractory multiple myeloma. Thank you.
Thank you very much, Eric, and also to the rest of the team of Myeloma 360. Over the next 10-15 minutes, I'll walk you through some updates on what we know for approved agents that are being used for patients in relapsed and refractory. Not all of them, but I will cover the most salient recent studies. In particular, I'm going to talk about small molecules and antibodies, so you have that in mind here. So these are my disclosures of people I've worked with, and in particular, I will say I'm biased in favor of considering transplant as one of the options for patients with myeloma. This is a work we published last year, and we asked ourselves a question. Okay, if you look at, we could go back. Thank you. If we look at, how patients are able to complete the various lines of treatment, how many of them then subsequently complete the next line? So what we call attrition. And the idea was we use a very large data set of patients, through real world. This is 22,000 patients in the upper part of non-transplant, and 2,000 patients in the transplant. And we said, how many patients complete the next line of therapy? And that is reflected by the percentages you see on the right. So as you see, as we go through the various lines of therapy, there's a shrinking population of patients that gets the subsequent line of therapy. So we all have in our practice as a patient we've treated for 5 or 6 lines of therapy, which is great. But the point is sometimes people cannot do that. Sometimes their disease becomes complicated. Sometimes they just don't want to get more treatment. And what I take from this is that we have to put the best treatment forward from the get-go. There is no point in saving good treatments for down the line. So we really have to put our best foot forward from the get-go for myeloma patients. And this study is not unique. Others have shown similar data. The Europeans have shown very similar data as well too. So that's something important to keep in mind. So I'm going to tell you about the studies now that have explored relapse and refractory. I think a landmark study was published by my friend Keith Stewart in 2015, which is Aspire. As many of you are familiar with the combination of the carfilzomib, lenalidomide, and dexamethasone. The commercial name is the Kyprolis for carfilzomib, but for the patients in the audience. And this showed a superiority of 3 drugs versus 2 drugs. And what you see in the curves are, the duration of disease control that we measure as progression-free survival, which was 26 months versus 17. Now, one of the messages I want to leave you all with from this talk today is in this particular study, the control arm is lenalidomide and dexamethasone, and that was 17 months. And while there are some exceptions, every single clinical trial that has looked at combinations in myeloma tells us that we should be looking at 3 drugs. So if you're a patient, I think it's fair to say that physicians should be discussing 3 drugs for the treatment of your condition. Now, there are exceptions to this, but if you face that, I would bring up the question, because this study, like many others, has shown that 3 drugs are better. Another study is a combination of daratumumab. Back then, when they did the study, was daratumumab, lenalidomide, and dexamethasone, or the so-called POLLUX study, for patients who had 1 to 3 prior lines of treatment for their multiple myeloma. They use intravenous. As we all know, daratumumab is mostly being used subcutaneous now. But the study was remarkable that it showed, once more, 3 drugs better than 2. In this case, the PFS at 18 months was 76% of patients had not experienced progression at the end of 18 months versus 50% of the patients on the doublet, which is pretty consistent with what we see with all of the clinical trials that have studied this particular doublet. But here in the United States, so as we think about the next line of treatment, we often think of pomalidomide replacing lenalidomide. So pomalidomide, the Pomalyst, comes in for combinations with daratumumab. So here we have it. This study is called the Apollo trial. It was presented at the ASH meeting. 3 drugs versus 2 drugs. If you note on the red box on the left, it says at least 1 prior line of treatment. So patients who had at least 1 prior line of treatment, but only 11% of them had only 1 line of treatment. The rest had 2 or 3 lines of treatment. And also, a significant fraction of these patients had high risk markers, so more aggressive disease. Once more, the study's in favor of the 3 drugs versus the 2 drugs. At the 1 year, 52 versus 35. Now, there's an important caveat and something that I'm going to mention for the first time here, and we'll make reference of for my other studies. Now, the studies, that I've shown you, many of them had big international participation. So a lot of these patients were not previously exposed to lenalidomide as maintenance after transplant. So that's something we're going to have to consider as we move forward and we think about what the options are for myeloma patients. Great responses. The left side, much better. Overall response rate, 69 versus 46. And, MRD negativity, and we can talk more about that, 9 versus 2%. So the study was frankly positive. Well, what about the other monoclonal antibody, cetuximab? So there's a very similar study. It's called the Aiello study, but now instead of daratumumab, uses cetuximab. Once more, 3 drugs show superiority. So the response there is 60 versus 35. And if you look at very deep responses that I show in the table on the right, the near CR is 15.6 versus 13 versus 3.3%. So this is just one more option that has opened for patients with myeloma. And when you track this over time, once more you see the superiority of the 3 drugs. In this particular case, it was 11.3 versus 6.47 months. So again, one more option. But then if you ask yourself the question, prior exposure to lenalidomide, what does that mean? Can we look at new regimens? So the best, I think, way to look at that now has been a couple of studies I'm going to show you. So Candor is carfilzomib, daratumumab, and dexamethasone. So this is an IMiD-free regimen. versus carfilzomib and dexamethasone. Again, 1 to 3 prior line of therapies, close to 500 patients in this important clinical trial. And once more, 3 drugs better than 2 drugs. The PFS in this case now, I'll call your attention to the numbers, 28 versus 15.2 months. So a significant difference in favor of the 3 drugs. So I think this quickly positions this as one of the desirable regimens for the treatment of myeloma. And in fact, if you look at this, the same thing with another monoclonal antibody with Aiello, which is again isatuximab, which we are fortunate to have now approved. So this study tested isatuximab, carfilzomib, and dexamethasone versus carfilzomib and dexamethasone, for similar patient population. In this particular instance, the median progression-free survival or the median duration of disease control not been reached yet, versus, we see that for the 2 drugs is estimated to be 19.15 months. So one of the biggest questions right now in the myeloma community is what is the optimal regimen for the first relapse or the second line of treatment? And until we hear better, I think both the data that we see from Candor and Aiello look pretty promising. We have patients that will respond very nicely to the IMiD-containing combinations, but this data has us definitely scratching our head. And as I mentioned before, MRD can be measured. We see a fraction of patients that can get into MRD negative, both with the Candor and the Aiello. I would urge you not to make direct comparisons between these 2. The point is not to compare them, but just to say that deep responses can be attained in the setting of relapsing multiple myeloma. Now, we have another antibody as well, too, the Eloquent clinical trial tested elotuzumab. Elotuzumab, as you know, has been tested in combination with IMiDs. So in this case, this was a publication now 3 years ago, time flies, by Dr. Dimopoulos in the New England Journal, where they looked at elotuzumab versus elotuzumab, pomalidomide and dexamethasone versus pomalidomide and dexamethasone alone, and the differences are 10.3 and 4.7. I would say in our clinical practice, we have not used as much the elotuzumab because while it is a very well-tolerated regimen, only a very small fraction of patients in this study had prior daratumumab. So we're not quite certain how we're going to position this as we go into the future. Now, I want to tell you a few words about 2 other drugs just before we come to the Q&A session. First, of course, selinexor. So selinexor, which is a recent drug approval for the treatment of myeloma. And what it does, it concentrates proteins that we call tumor suppressor genes in the nucleus of the cell. So it augments, accelerates the activity of these proteins in the nucleus of the cells, proteins that keep the cancer cells in check. So we're hoping that, that would work. And it's been approved in combination with bortezomib and dexamethasone. I'll show you why, but also in combination with dexamethasone. And the why is this clinical trial? It's called the Boston trial. We first saw this at the ASCO meeting last year. So it was 3 drugs once more, the S, and by the way, you'll see selinexor referred by an X as well too. So S or XVD versus VD for patients who have prior therapies for multiple myeloma, 1 to 3 prior lines of therapy. And long story short, the study was frankly positive, and the results are here. So the 3 drugs was 13.9 versus 9.46. So, I mean, this, I think, showed a great proof of principle of the activity of this drug. I think it cements sort of the information we need as clinicians to be able to say, we can use this drug and we'll use it in other combinations as well, too. And in particular, if you're a patient, I know you probably have heard quite a bit about some of the side effects that we have with this medicine. I'll talk more about this. But we've learned a lot better how to use it. And this particular clinical trial uses selinexor on a once-a-week basis with the right antiemetic. That means that anti-nausea preventive medicines with much better results than we could be achieving in the past. Now, one of the things I want to point out here is that this is what we call the forest plot. So it looks at the subgroups of patients. And this is always fraught with, uncertainties and some challenges. But one of the things we learn with this is patients who have high-risk markers seem to derive particular benefit from this, especially patients with chromosome 17 deletion. So we're going to study that more in that patient population. Now, I alluded to the fact that we know how to better use this. And again, if you're a patient, I think your doctor needs to be very familiar with this. So it needs to be used once a week, not twice a week. And then we preventively just start with a triple antiemetic regimen. So, there's a little bit with the dexamethasone. Around the clock, the ondansetron that is called isofran, you might know this better. We tell our patients to take this around the clock for 2 days. And then we also use another medication called olanzapine at nighttime, at least for the first month. And if patients can get through that, then we find we're able to actually effectively control their multiple myeloma. Lastly, just a few words about the other new drug, and that's belantamab mafodotin. This is also called Blenrep. It's an antibody, but unlike the daratumumab and the cetuximab I showed you before, this antibody has a little warhead that's kind of like a Trojan horse. So it brings a poison inside the cells. That poison is called MMAF, and this just disrupts the machinery inside the cell. So it's literally a poison that works effectively and has good activity against multiple myeloma. There's a number of trials. You'll see, the name of DREAM associated with all the trials. And let me just suffice it to say that we do have good evidence of efficacy single agent. So of course, we're trying to combine this. If you're a patient too, you may have heard about the toxicity, which is something we are concerned or wanting to learn how to manage. And that is there could be inflammation in the lining of the eye, the frontal part, what we call the cornea. So that's described as keratopathy. But I would say, just like I said for selinexor, every single myeloma drug has started at the start line with some toxicity. Then we later on learn how to manage it, how to prevent it, change the dose, change the schedule, and have been very fortunate to get through all of that. We started with high dose dexamethasone, started with thalidomide at 800 milligrams. We started when we used to use bortezomib injections intravenous twice per week. A lot of that has been improved upon. And I don't want to forget about this, of course. Melflufen is another medication just recently approved for the treatment of patients with relapsed and refractory multiple myeloma that were treated in this Horizon clinical trial. And you see there in the bars the response rate. This is an intravenous medication. It requires the placement of something like a PICC line, at least for its administration, but it's able to have anti-myeloma activity. So I think we're going to start seeing combinations, just like we see combinations of all the other agents, the carfilzomib, you've seen that with the daratumumab. We're going to start seeing combinations with melflufen. So just to conclude, on being mindful of time, we have many new therapies. You're going to hear from Dr. Berenson about the new drugs. I counted at the last ASH meeting at least 15 compounds that have promise. And we are learning how to better manage the toxicities. Each one is different. A lot of this relates to the experience of your doctor. And again, thank you for your attention, and I'm happy to take some of the questions. So back to you, Eric.
Thank you very much, Dr. Fonseca. Really awesome, very clear talk, and thank you so much for keeping to time. You got through a lot of information there very clearly and very quickly, so thank you very much. So the questions are trickling in. The first question that...
read them, or I can read them from here if you want me to.
Okay, go for it.
So yeah, so myeloma patient for the past 18 years, last year on daratumumab until the bone marrow showed no CD38. The numbers rising, went on to selinexor. It was way too toxic, and I stopped after 2 months. So then the numbers started to rise, and I went to belamaf. The treatment put me in a complete remission, but it causes severe eye pain. It's like every toxicity we talked about right here. So my last treatment was February 25th. I still have pain in the eyes and poor vision. I don't really want to take this treatment again, though it just kept me in complete remission, and for the obvious reasons. What would you recommend? Well, it's hard to make it specific because, and I know you put there some of the other treatments just to kind of put it in general for all other patients too as well. I would explore both the agents, some of the ones you have received. I don't see there the carfilzomib, but that would be one of the considerations. Of course, we have the commercial availability of CAR T cells, which might be of interest in your particular situation. I've used in patients who have failed to respond to daratumumab in combination with carfilzomib, as I just showed you in the other regimens, so that can be effective. And last but not least, of course, a clinical trial. Clinical trial is one option that can bring new opportunities for patients. In particular, right now, I think bispecific antibodies. So Anyway, so that's something to consider. And you also put a comment here, James, regarding the estimated MRD value. So what you see there, for those of you who are not familiar, so you send the cells to the laboratories of Adaptive. In this case, they sent 3.8 million cells, and they found 1,000 cells. So at first glance, you might say, well, I'm concerned because it's not negative. And sure enough, the number we want to see there is 0. But 1,000 copies is actually pretty good. And there's something that we can use from this data that is useful to as well. And we don't talk enough about this in myeloma. And that is that you can use that 1,000. And if the collection process has been standardized, you can use that almost like we measure the light chain. So I can tell you if it goes from 1,000 to 100 with whatever treatment you're getting, and assuming the collection is very similar, that might mean that you're in the right direction. You cannot measure that with a protein or the free light chains or anything else. So I'll leave it at that. Thank you for the question. What is the treatment for people whose first diagnosis was a coexistence of myeloma and MDS, Adolfo? So thank you for the question. This can be very challenging because you want to provide the treatment, but sometimes the MDS, and for those who don't know, MDS is a condition where happens commonly with age, and the bone marrow kind of ceases to work 100% like it should, and so you usually have low blood counts. So you have to be mindful of that as you go through the phases of treatment. Adolfo, I don't know what your situation is, but in some circumstances, if the MDS is very advanced, the primary treatment of that has also been bone marrow transplantation of a different kind, the allogeneic transplant. So that would be a conversation to have with your doctor. But if you're not in the category that you would benefit from that, or in the age group, I think one has to be very careful about making sure you have the right doses for the medications for the treatment of your myeloma. Ellen, a great question. What is the data with using isatuximab in patients who have progressed on a daratumumab regimen? We have very little information. It's pretty standard practice in oncology. If a drug doesn't work, then we switch to something else. But we don't know. I would cross my fingers to think that maybe isatuximab can rescue situations where the daratumumab stopped working. But we have a little bit of conflicting data in a very small series to even make statements about this. So it's possible it won't work, and perhaps in some patients it will, but unfortunately, that's where I have to leave it right now. And there's another question here. First round of RVD, 12 months, good initial response, then 7 months later, 30 to 40% plasma cells from the bone biopsy. Recommendations for a second round of treatment. Well, the good news is there are many treatment options, and in someone who's treated like that, the first, of course, reaction would be RVD. So the patient has not seen pomalidomide, the patient has not seen carfilzomib, the patient has not seen daratumumab, and if in the right age category, stem cell transplant could be a consideration. So I think those are all great questions. Thank you for bringing them forward. Now, Eric, truly back to you. I think I've answered everything that came here in the.
You've made my job very, very easy, Dr. Fonseca. So thank you very much. I've just got one question for you before we move on to Jack.
Sure.
And keeping in mind that Dr. Berenson's talk is kind of coming up. What is the unmet need in relapsed refractory multiple myeloma? Because all the treatments have got upsides, some have got downsides. There's a decent magnitude of response, duration of response isn't great in all therapies. So what are you looking for in the pipeline? What do you need in relapsed refractory multiple myeloma that will give you a good balance between magnitude of response, duration of response, and manageable side effects?
So I'll tell you two things. Number one is we need treatments that are short-lived, that produce very deep responses, MRD negative, because we are seeing that if you can achieve that, that usually translates into long-term disease control. So I would say that's the number one medical unmet need. But one of the very interesting things that patients should know, let's say you got treatment, and some of the patients in the LAs, maybe they got CyBorD, 7 years ago and had a transplant, and then with or without maintenance, you're on treatment. And a few years later, the myeloma unfortunately surfaces again. There are some more treatment options now that I think a first relapse should be considered as second opportunity to go big with what you're trying to do. And I would in that situation, I would try to go aggressive.
Sure, thank you. Okay, brilliant. So I think we've answered all the questions. So just in the interest of time, we'll move on to Jack now. But massive thank you, Dr. Fonseca. And we know that you have to leave, so thank you so much, and enjoy the rest of your day. Thank you. So, Jack, I'm not sure you need any introduction. So yeah, Jack, over to you.
Okay,
Thank you.
so let's go on to the next slide. Perfect. So my myeloma journey started 26 years ago. And when I talk with newly diagnosed patients all the time, and I will tell them that the good news today is that there are an awful lot more treatments available, as you just heard Dr. Fonseca say, and you'll hear even more that are in trials from Dr. Berenson. That's the good news. The bad news about today is that you really don't know what treatment is best for you. And it's so important to have specialists on your medical team, like these doctors, who really are familiar and only are working with myeloma patients and involved with these clinical trials. When I was diagnosed in 95, the decision was quite easy for me. There were only two treatment arms. One was melphalan-prednisone. These were pills that you took. But if you were transplant eligible, that was the gold standard. In fact, I had a couple of transplants, a tandem transplant in 96, got into a great remission, but it unfortunately only lasted a year and a half. I did my first clinical trial for thalidomide in early 98. That didn't work for me. Tried some other chemo combinations, which didn't work. And finally, I had only one other option available to me in 98, and that was to have a full myeloablative allo transplant. An allo transplant is where you receive your stem cells from a donor instead of yourself. The problem, and that worked well for me. The problem with allo transplants, though, is they have a high mortality rate. And today, with so many more easier and effective treatment options, allo transplants aren't done too much anymore. I did have some graft versus host disease and some plasmacytomas that had to be radiated, but since 2002, I actually haven't been on treatment. But my neuropathy, probably from thalidomide, and fibrosis, probably from radiation, progressed to such a point where those side effects caused me to go on medical disability. So since 2002, I've been advocating quite a lot for myeloma patients. You can go to the next slide. I'm focused. I have a support group in the Bay Area, San Francisco Bay Area, that's large, but I'm an advocate on various committees for NCI and SWOG and CIBMTR, where I offer a patient's perspective on new treatments available. So from 26 years of experience, these are my tips and recommendations I would give to you, the patient. As I said, it should already be obvious that it's important to get a myeloma expert on your team of medical treatments. You can already see that they can offer so much information in terms of what's available. I think it's key that you be your own best advocate. Do your research. There's lots of good organizations available today, myeloma-specific organizations. There are myeloma-specific support groups. There are webinars like this. Even though we are all individual patients and our responses are different, it's good to get other patient interactions. You'll learn to ask what are the best questions to ask your doctor about in terms of what side effects you might experience or what treatments might work best for you. The fact is, for myeloma, treatments work for a while, then for the most part you relapse, then your next treatment will hopefully work and relapse, and you repeat. I would say it's important to avoid those emotional highs and lows that come with treatments working and relapsing, because honestly, that can drive you crazy. I would also say it's important to accept help. help can come in the form of friends. You know, friends are always saying, what can I do to help? I can remember one of my friends saying, I'll prune your fruit trees for me. That was a significant help. But there are other ways that patients and friends of theirs will help. They may drive them to an appointment. They might want to monitor labs and look at the trends of how you're responding to treatments. I think it's awfully important to make sure for yourself and then for all your medical team to know what your preferences are. You know, overall survival, which you saw in various figures presented by Dr. Fonseca, seems obvious. I want to live as long as possible, but to what degree? You know, it's going to impact perhaps your quality of life. It costs money for these treatments. Side effects are important. The convenience of treatment. So you need to kind of understand that information for yourself and then let other folks know what's important for you. I guess I would end up by saying, and I wrote there, knowledge can be your best medicine, but all of this needs to be in a shared decision-making environment between you and your medical team. Realize the impact your disease and your treatments are going to have on caregivers in your family unit. I think I'll stop there because I hopefully I've given you some important points for you to be your own best advocate.
Thank you, Jack. Again, very clear. You got through that quickly and lots of kind of good content in there. I don't see any questions coming in. So folks, if you do have questions for Jack, get them in kind of quickly. In the meantime, I'll maybe ask Jack a couple of questions. So given that myeloma is very heterogeneous, people are different, patients are different. You get shy patients, confident patients. What advice would you give patients who struggle with being proactive, struggle with information, don't have the confidence to be a good, strong patient, can't articulate their preferences? How can we help that group of patients? Because we're all different.
Yeah, you're right, Eric. We have those patients making their way sometimes to our support group meetings, but they'll be the quiet ones, or they'll be the ones that will say, I just do what my doctor tells me, and that's what's works for me. And that's okay. We're all different. I hope that they, though, will expose themselves to meetings like this, webinars, where you don't have to say anything. You don't have to ask questions. Even support groups these days are typically done by Zoom and virtual, and you can remain pretty quiet on that, and so on. So, and then the other thing to remind them is that there are oftentimes caregivers who do want to help and do want to be part of their medical team and do want to go with them to their doctor's visits and such, and can be the spokesperson or the person who wants to get educated about their disease. And the patient should lean on them to make sure that they are an active help in there as part of their medical team.
Brilliant. Thanks, Jack. You can probably read this question. I'll read it anyway. Your journey has been long and difficult. You're an inspiration. You're an inspiration. And looking back, is there anything you regret doing or wish you had done differently in regards to your human care? And it's a big thank you and stay well message for you as well.
Well, it's an interesting question. I learned a long time ago, don't look back and reconsider your decisions. And that's all part of that, of avoiding the emotional highs and lows. I do remember, though, when I was first diagnosed, one of the doctors told me that I could start off getting an allo transplant. And I wonder, would that have been better for me in the long run, as opposed to avoiding the initial transplants and the thalidomide trial and so on? But, you know, there was also a risk factor taking that transplant, the allo, which has essentially a 40% mortality rate just from the transplant. So I think for me, I've made the right decisions. I paid with some side effects penalties, but the fact is they were the options available to me at the time. And I was dealing with myeloma expert doctors who were making these recommendations and answering my questions to the best of their knowledge.
So Jack, just reflecting on that decision to have the full Aiello, I remember these days vividly, and it was a massive dilemma for patients. They were stuck between a rock and a hard place because they probably weren't going to live long with melphalan and prednisolone and cyclophosphamide. But the risk, the 40% mortality rate with the allogeneic transplant was massive. What criteria did you apply to that decision making? What ultimately tipped you in favor of that allogeneic transplant? And to what extent were your family involved in that discussion and decision as well?
Well, to be honest, Eric, it was the last available treatment available to me. There was no other chemo. There were no other clinical trials available to me and such. My family was heavily involved because I ended up having this transplant 2,000 miles away from where I live. And I had to have a caregiver with me, and the transplant was stem cells were coming from my sister. So there was a lot of coordination effort, a lot of concern. But like I said, the decision got to be fairly easy at that point since it was the only one left for me.
Sure. Thanks, Jack. Another question that's come in: how often do you see your physician, and what do they monitor to check for relapse?
Yeah, so I see my physician every 6 months. She has said she's comfortable coming in once a year, but I actually feel better a little bit every 6 months. And I do the regular blood tests, monitoring my myeloma markers. About every 2 years or so, I still might do a PET scan or an MRI, sometime imaging diagnostics. But otherwise, I pretty well stick to that schedule. In fact, I have an appointment next month.
Wow. Well, good luck with that one. But if you were to take an average, let's just say for members of your support group, taking account of the fact there's newly diagnosed patients, there's late stage patients, there's high risk patients, on average, how often would you think a myeloma patient would attend their doctor's clinic?
I would say minimum every 3 months.
Okay.
And maybe even more frequently than that. It really depends on the patient and what their progress is. They might be in a clinical trial, which makes them typically get more monitored. And I didn't mention anything about clinical trials, but boy, that's an important option for patients as well, in terms of considering that, because you can get access to really excellent new treatments then, as well as excellent attention from the doctor who's administering that trial.
So I think we've got time for maybe one more, maybe two more questions, Jack. So another one's come in. Do you have any advice for physicians and nurses, in particular, concerning things to avoid doing or saying to their patients or to family members?
I guess I would, it's an interesting thing I see about myeloma patients. They are very educated and they want to ask questions for the most part. And I emphasize that it really is important to make this effort be part of a shared decision-making effort. The doctor and by the way, nurses have wonderful information is available as well, especially when they're handling and looking for side effects and such and how to treat it. But the doctors will and should be amenable to, one, making sure that if you are not a myeloma expert, that you're encouraging your patient to also get a myeloma expert as part of their medical team. And then two, make sure that we know that it's not well known how well a patient will respond to a given treatment. And as you saw from Dr. Fonseca, there are several treatments out there. So when you are suggesting a next treatment for a patient, there's nothing wrong with suggesting 2 or 3 and have the patient involved in making those decisions, because um, some patients will say, I'd just as soon be on an oral medication because I still want to work and I don't want to have to come in for a 4-hour infusion of a particular drug. So make sure that the patient is part of that shared decision making in terms of what treatment might work best at the time. And then I always like to look one step ahead. One of the things I heard best from a previous myeloma patient is that you should almost treat myeloma like a frog on a lily pad. The frog is getting his sun, but at some point they know the lily pad's going to sink and they're ready and have their eye on the next lily pad to jump to. Mm-hmm. Patients and doctors, I hope, always keep in mind that there always needs to be a next lily pad to jump to, and have in your own mind what that next lily pad might be.
Great, thanks, Jack. So one quick question for me is, you talked about patient preferences, and that can often be expressed in the context of potential benefits and potential risks. And the balance of potential benefits and risks will obviously vary between different patients at different stages of the disease, different stages of their life, etc. But in general terms, what would you describe as being an acceptable level of a ratio between benefit and risk for a patient in the relapsed refractory myeloma setting?
You know, that's such a hard question to answer, Eric, especially from my own perspective. When I was on the clinical trial, let's say for thalidomide, I really didn't experience neuropathy, but it was something that grew over time. So not only can you have risks that are short-term, but they can also be long-term. I guess the answer to your question is very individual. I would want to say that the important part is what type of quality of life do you want to maintain? If you're working full-time, do I still want to work full-time? If I want to bounce grandkids on my lap, am I still able to bounce grandkids on my lap? And any treatment that allows me to effectively still maintain that part of quality of life that's so important to me, I think is certainly within the realm of a treatment you should consider.
Awesome. Thanks, Jack. Brilliant, brilliant answer. So thank you so much. We're going to move on to the next presentation from Dr. Berenson, who's going to talk about the future treatment and what's in the pipeline for relapsed refractory myeloma patients. So thank you, Dr. Berenson. We're looking forward to your talk.
Thank you, Eric. Thanks for joining us this afternoon. Oops, we don't seem to be moving the slides here. Okay, so we know today there's incredible vast array of treatment options for myeloma patients in the front line and in the relapsed refractory setting. And if you look at the bottom there in the white part of the slide, and you count those up, there are 19 different agents that are listed. Whereas when I started, you heard from Jack, we had melphalan and maybe steroids. And there are a few other stragglers on here that they haven't listed. And you can see all these different combinations that are been trying, from smoldering to the second line, and triplets, and now quads as well. Whoops, my little my little photo thing here. These have a variety of different efficacies, and as Jack mentions, importantly, side effects. And it's our job to make our myeloma patient have the longest life possible. And I always say with the least impact, not only from the disease, from the treatment, as you've heard from Jack. So we've had a plethora of approvals in the last 12 months. I remember March 2nd, it was the last time I was out of town. I also was with Blake Morrison, who's part of Myeloma 360 up in the Bay Area on primary day. The last time I traveled, and that day was when isatuximab was approved for treatment. And you saw the data from Rafael combining it with POM and DEX for patients who'd seen at least 2 prior lines of therapy. And in the summer, we heard it from one of the people asking a question about belantamab and its approval. It's an antibody that targets, it says CD38. It actually targets BCMA. It's for patients who failed a CD38 or a number of other treatments, but you can see it's got eye problems from the question. And then a few months ago, we had the approval with selinexor with Velcade and Dex. That drug was previously approved just with Dex alone, and adding more into our quiver, arrows to shoot myeloma. And then just about 7 weeks ago, a variation on our first drug we used in myeloma when I started 40 years ago, melphalan, with it's got peptides hooked on to it, so it can be more increased in its efficacy in myeloma versus other cells in the body. And then just recently, last month, we had the approval of our first CAR T cell in myeloma, ide-cel, for very heavily pretreated patients. And isatuximab just approved in combination with carfilzomib and Dex for patients who've received 1 to 3 lines of therapy. So you can see how rapidly things are moving in terms of treatment. And I want to make it very clear that there's a lot of new things on the horizon now for myeloma. Okay, so the emerging therapies for myeloma patients today in the relapsed refractory setting are including antibody drug conjugates that target BCMA, CD56, CD38, and CD74. We have these alkylator peptides, including, importantly, the melphalan. We have CAR T cell therapies, and we have a variety of other BCMA targeted drugs we'll be talking about. Immune checkpoint inhibitors, I won't say much about. Vaccines, won't say much about. We'll talk a fair bit about bispecifics and T cell engagers and the cereblon E3 ligase modulators. And I'll mention our work with JAK inhibitors in the lab and clinically as well. So the bispecific antibodies and T cell engagers, these are antibodies that have 2 parts to them. They connect the myeloma cell to the T cell, which is the effector immune cell. And this leads to that T cell. That was my first work in cancer biology back when I was a 22-year-old in Seattle, showed that T cells kill tumors. And now we can figure out how to make them do it better, for example, with these bispecific and T cell engagers. So these so-called BiTEs, they activate the T cell, leading to its growth, production of proteins called cytokines that make them more effective, immune regulation, and induced death of the myeloma cell and tumor cell elimination. So basically, it's kind of like the waiter. I took my first meal out last night for our anniversary, and it's like the waiter kind of bringing food. It's bringing the T cell to us, and us being the myeloma cell, if you will, and it kills it. And there are a variety of different manipulations that have been done to make these highly effective to treat myeloma. And there are a bunch of trials now with these BiTEs being done. It's a huge list of phase 1s here. I think we have about 8 on the list. They have a lot of fancy names. Efficacies vary from about 30%, you see up to 80%. And they are fraught with some toxicity. Specifically, you can have what's called cytokine release syndrome, or CRS, which can be quite daunting. And you can see a variety of listed cytopenic effects, low lymphocytes, anemia, low neutrophil counts, and those are certainly can be problematic for these agents and have led to some of them not moving on to further development. So one has to be a little cautious here, but this is a more specific approach, bringing the T cell to the myeloma cell. And the CAR T cells are modified, the T cells themselves are modified in such a way as, again, to target the myeloma cell. So they have an activation construct, a stimulation that in the right side cartoon that for IBB or the CD28 or CD3, those that are activators. And then you have a target antigen. In most cases, it's BCMA, but there are a number of other ones that are being tried. So you activate the T cells with this construct, and then those T cells also have an ability to target the myeloma through this BCMA, if you will, targeting. And the way that's done is shown at the bottom. The T cells are collected, and then it takes a few weeks to grow them and construct them, and then they are given back to the patient. So the patient has to be stable for a period of time while these T cells are being activated. If they're not going to be in a position to get them. There's a lot of data now being emerging from a variety of these and a lot of different trials. We just saw the approval of the one listed down there toward the bottom, Aiello. This is now approved for myeloma as of just about 3 weeks ago, very boosting high response rates and in some cases even MRD negativity. There certainly is a fair degree of cytokine release syndrome on the right-hand side, as you note. It varies a lot. There's a lot less of the grade 3 these days as we know how to handle this better. The response rates vary from the 30s up to the high 90s, again, with a fair, decent proportion of them in complete remission. So antibody drug conjugates, we just heard about belantamab in a minute, from a moment ago, from the patient standpoint in terms of the eye issue. These are antibody drug conjugates. And basically the antibody targets a protein on the outside of a myeloma cell. It may be BCMA, it may be something else. And those little red explosions are toxins. And so this gets internalized into the cell, those little red explosion things you see in the cell cartoon on the right, and then you're able to concentrate that and kill the myeloma cell and leave hopefully the rest of the body alone by this concentrating effect for targeting myeloma with an antibody to BCMA. So there are a bunch of ones being done now. This is one that was presented at ASH in 2020. Phase 1 design trial in a very heavily pretreated patient. This is a phase 1, so you're dose escalating from a tiny dose, the starting dose, which is way down there at the bottom left, and then you're boosting up, and then they decided to expand between the top 2 doses in the green square at 0.14 milligrams per kilogram. And that you see efficacy data for that dose in the green rectangle, and you'll note there are about 2/3 of the 41 patients treated that dose responded to this particular agent, and that looks pretty promising. We don't have a lot of data on how long those will last. Interestingly, there's now follow-up drugs on the immunomodulatory agents. They've been termed now cereblon E3 ligase modulators, or cell mods. And basically, these drugs, like the older versions, thalidomide, Revlimid, and I can't believe I'm saying older, pomalidomide, would bind to these cereblon E3 ligase, and those then will induce the degradation of what's called Ikaros, a number of other factors through the proteasome, and that makes myeloma unhappy, and it goes through what's called cell apoptosis, or death. We've learned over the last few years that is how cereblon works, and we've learned that these newer cell mods, iberdomide and the CC92480, are better at this than the older agents, and therefore hopefully going to be more effective. So the two that we'll mention briefly are the 92480 phase 1, efficacy 21%, response rate. The iberdomide, 42% response rate. There's a fair bit of toxicity. You can see a lot of grade 3-4 cytopenias and infections, especially neutropenia of import, but also low platelets and anemia. Other agents for relapsed refractory disease, we're doing a lot of work in JAK inhibitors. This is a drug that's been approved for a number of years for polycythemia, myelofibrosis, and recently for graft-versus-host disease. The BCL2 inhibitor, venetoclax, approved for lymphoma and leukemia, but it's also known to be active, particularly in patients who have the translocation 11-14 biomarker. The immune checkpoint inhibitors were approved previously for a lot of solid tumors and select lymphomas, including an approval today. Early data suggested these inhibitors would not work very well in myeloma, And there's some concern combining these may be toxic in myeloma, and it's inhibited further development of these inhibitors for the treatment of myeloma. There's a number of vaccine trials in development. We don't really have a lot of clinical data at this point, more just immune data in terms of how they work. So the JAK inhibitor story, we've done a lot of work on this over the last 5 to 7 years. We've now brought it in as an agent to be used alone with steroids for treating patients with relapsed refractory myeloma. We did earlier work in phase 1s, and we showed that this 15 milligram dose twice a day we like to use oral Medrol. We think it's better tolerated than Dex once a week. And and if they progress, and we add Revlimid, which we've shown very effective in combination with ruxolitinib. So this data is from the ASH meeting in December, in which we demonstrated that about half these patients responded to this treatment. And these patients were refractory to a lot of different things and had a lot of heavily pretreated disease. And there were even patients who achieved, as you can see, very good partial responses. There were a few patients who had infections, but it was incredibly well tolerated. And remember, this is a pill. And then I'll mention venetoclax. This is a BCL2 inhibitor. In the days I was working on these, we called them NERDs for non-express rearranged DNA. We now call them oncogenes, BCL2 being the first one. And although on the left-hand side, the efficacy in the green bars was higher when venetoclax was combined with bortezomib, otherwise known as Velcade and Dex, on the left-hand side, you can see there's good efficacy compared to Velcade Dex alone, or BD. But in the right-hand side, in the rectangle, there were actually more deaths, especially in patients who did not, in the right-hand bottom graph, did not harbor the 1114. If they did on the left-hand bottom, they did better. And this has led to a lot of interest in using this drug, particularly for patients who harbor this particular genetic marker in myeloma. And we have been exploring that recently with the treatment of that among patients with the combination with daratumumab, bortezomib, and Dex. And you can note at the bottom in the red, we're using lower doses of bortezomib, lower doses of venetoclax. The approval doses are 400 to 800. And what we've observed is excellent responses among patients with a translocation 1114 in this 4-drug combination. Very few side effects, much lower response if you lack that 1114 in the bottom. So the future state of myeloma and multiple relapses, those that are refractory to IMiDs, PIs, and anti-CD38 combinations with Cytoxan that do not have these drugs, anti-BCMA strategies, and those refractory to alkylators and anti-BCMAs. There's a lot of existing drugs we often forget about, and there's a lot of new drugs in the right-hand bottom in development. And in the final slide, I will tell you that increasing our understanding through the laboratory, the mechanisms underlying myeloma, especially its resistance mechanisms, has resulted in a lot of novel approaches, novel combinations of already existing drugs, and adding agents to overcome resistance, as we've done with ruxolitinib, for example. Lower doses and alternative scheduling can be highly effective and better tolerated. And I think if we can repurpose drugs, which we've done with ruxolitinib and now with venetoclax, may be very hopeful to expand the armamentarium for myeloma patients. And immunotherapies may be helpful, but we got to be careful with toxicity with checkpoint inhibitors, vaccines, we're not sure. Certainly the BiTEs and the CAR Ts are very promising, as are the ADCs. So we're going to need to figure out how to optimally sequence the treatment and how to better specifically choose treatments for an individual patient. Thank you.
Thanks, Dr. Berenson. Again, thank you so much for getting through a great talk with great clarity and on time, really fantastic. So there's a couple of questions coming in. I guess the first one to sort of add to it is that, just building on some of the things you said in your conclusion slide there, I guess if you look at the pipeline, it looks incredibly stocked. It's actually, I kind of want to go and lie down when I see the multitude of different trials and things that are happening. What are the pros and cons of a stocked pipeline? And if it was up to you, looking into that pipeline, what things do you think show the most promise and you would pull through the system? And which things would you kill and say, no, that's not going to work? Let's stop doing that and let's put all our efforts into pulling these much more promising treatments through the system.
Well, that's obviously a very complicated process to figure out how to do all that. I'm certainly a firm believer that we should take things a lot of times slower, that many patients with myeloma get overtreated with too many drugs, experiencing too much toxicity. I think we have to be very careful about that. I think we have to be very careful about underestimating the toxicity of drugs from the vantage point of people that may be inclined to underestimate it for other reasons than patient care. I see that every day in clinic as I see 25 to 30 patients every day with myeloma, and I see what they really go through. And I think that's important. In terms of drugs specifically, I think the future is specificity. My good friend Gio on our board, who taught my wife, a lot of theater back in the 90s, and he's now on our board, prominent lawyer in LA. He used to say, it's not about more, it's about being more specific. And that's my credo. And I think we've got to kill the myeloma, not the patient. I think our feeble attempts to do this with what I thought were targeted therapies with proteasome inhibitors and IMiDs has now come about now with targeted proteins such as BCMA. Not perfect, but better. Ultimately, I'd like to target the genetics in the cell. I don't think we're there yet. So I believe that we need to move to more targeted approaches. However, I have patients who've had sustained complete remissions with less targeted therapies.
Sure.
So I think we don't know the answer. I think the future is going to be how to identify what's right for each patient. We're working on a initiative now to do that ourselves in the refractory setting. You know, there have been a number of attempts to do this in the front line. I think that's not where we need to work. You and I know in the front line, it's easy to get a response. You'd have to be kind of poor doctor not to get a response in front line these days. What we really need to do is how to identify what's best for that patient as they move along this journey on their 5th, 6th, even in some of my patients. I had one yesterday, 17th line of therapy. So what am I going to give that patient? That we need to do in real time. In future time, I think it's being more specific and getting to targets. And I think that that will allow us to kill the myeloma and hopefully leave the rest of the patient alone. That's what we really need to do.
Yeah. So when you say specific, the specificity is in the laser sharp focus of targeting the things that are implicated in the onset and progression of myeloma without causing any side effects, as opposed to being able to specify personalized, stratified medicine for different cohorts of patients based on their genetic.
I think it's really both. I think that there's approaches here. It can be the microenvironment. We're doing an IL-18 antibody trial to deal with that. It may be the immune system boosters. We're doing trials with that like everybody else. Or it may be directly to knock out that myeloma cell with a drug that's going to get in and only be active in the myeloma cell. And if you can do the last, which I think is the hope for the future, because I do not think the immune system is going to get repaired properly in myeloma patients. We're seeing that now with our COVID-19 antibody studies we're doing in the myeloma population. To get around all that, just knock out the myeloma cell, get rid of it. So it's not there to orchestrate bad things happening.
Okay, thanks, Dr. Berenson. There's a couple of other questions coming in. So considering the pipeline of potential treatments, what is missing? What else should we focus on? So what is missing from the pipeline? Is there a particular mechanism of action or specificity that we need that isn't in the pipeline?
Well, I think that's a very good question. I think we need to, as I mentioned, repurpose some drugs. We can bring drugs in that are already around. I think that, we've done a lot of work around the JAK-STAT pathway. I don't think that's been very well explored in myeloma. I think there's a lot to be done in the checkpoint arena. I think we got scared away because of the data that emerged about increased toxicity and deaths when it was combined with some of the immunomodulatory agents. I think that may get reinvigorated. I don't think that'll be a final answer, but these people need options over time. And I think that would offer some more options. I think the BCL2 story is really interesting and maybe the beginnings of us trying to individualize treatment better. I think we need to be able to do that with patients rather than give everybody RVD or whatever it is of the day. I think we need to do better.
Great. And just another question here, I'm going to sort of just, I guess, spin it a little bit, is around, is cure the panacea, or is turning myeloma into a disease that people live with rather than die from the goal? Because they're kind of similar but very different things. And sort of thinking about the median age at diagnosis of most patients is somewhere in their late 60s, early 70s. If you think about average life expectancy, even for perfectly healthy people, is cure the ultimate goal, or is turning myeloma into a chronic disease where people can live for a long period of time and average life expectancy with good quality of life?
I actually have a third possibility I'm going to mention in a second. I think the goal is going to be different for different patients. There are subsets of patients I have, including my longest living one at 36 years, who's never responded to anything. Now, why is that? He's got active myeloma by all the definitions. So his goal is chronic disease. Whereas the patient I saw yesterday with spinal cord compression, severe anemia, and a whacked out marrow, that patient better get cured, because I don't think that patient's going to be one we're just going to be able to do chronic disease therapy. It's going to vary. It's not going to be the same for everybody. But I think there may be another way to go. And that's what if we had a treatment where we could wipe the myeloma out to those MRD negative numbers, which I don't think mean there's nothing left. But you knew every time it came back, you could whack it again with what I hope the future is, a treatment that only knocks out the myeloma. Wouldn't that be fantastic? You'd know when it brewed its ugly head again, you'd whack it again, kind of like when you're at the amusement park and you're whacking with a hammer, those clowns coming up. And you don't have to worry. You're never going to have to worry about the word cure or not cure, because you know you have something's going to work every time. And it's not going to be toxic. We're not there, but I think that's a third possibility that we need to entertain as we think about the future of myeloma.
And just a little bit on high-risk myeloma. I mean, we haven't really talked about high-risk myeloma either at diagnosis or in the relapsed refractory setting. Typically, patients with high risk don't respond well to currently available treatment. So what proportion of the research effort should be focused in high-risk myeloma? And if we crack high-risk myeloma, are we also going to crack low and intermediate risk myeloma?
Well, I think we're doing a lot better with those folks. I mean, all these new drugs we're using are certainly showing much better activity than without them, whether it's antibody, whether it's, drugs like the proteasome inhibitors. Very clearly, we're showing beautiful data now that you add those in and you make these people look like standard risk, a lot of them. That's not as true for chemotherapy. But risk things are changing a lot now. I mean, it's really interesting. 11-14, we said, oh, it's really good. Then we said it's really bad. Now with 11-14 and venetoclax, maybe it's good. So these risk categories are going to change as these therapies evolve, and find out as we do more research that, for example, with some new drug, maybe the high risk is now the low risk with that drug. We have no idea what the future will bring here. So sure. I think I wouldn't want to be that myopic about it. I think I'd want to be kind of open about it.
Great. Thanks, Dr. Berenson. I'm surprised that it's taken so long, but we have a COVID-related question. So what can myeloma patients expect from vaccinations?
Well, we
presumably,
we were fortunate enough to get support from several patients who like to run around the world, that they supported us doing a giant study, which we're doing now in about 175 of our patients. And we're gathering the data 2 to 3 weeks after the first and second vaccines, and then 8 weeks after the second one in a baseline to see if they respond. And there was some data last week from a group suggesting that the majority of myeloma patients will respond. I don't think so. I don't have enough data to give you a final answer on that. Given what we know about response to flu, another similar vaccination, I think it's going to be a minority. And I think it'll be those who have fairly normal antibodies, those who have uninvolved. So if you're an IgG, if your A&M is more normal, I think you're going to be more likely to respond. We also think our new analyte BCMA will predict that as well, because it's really a marker for your B cell function. But I think you've got to be, like I have a bunch of patients in today who want to do things and travel. And I'm like yelling at one of them's wife who refuses to get vaccinated. And I said, it's more important she gets vaccinated than you, because you don't want her bringing it home to you. But I think that the lack of antibodies is going to impair the response to the vaccine. More to come. We should have data in the next few weeks on this. We're doing a lot of work.
Excellent. And how will that data be disseminated? Because I'm conscious there's a lot of patients on the call, on the webinar today. So how will that information be disseminated?
Very quickly. I have the nice thing is I'm working very closely with a guy at Emory who's an expert on COVID that's right across from CDC. So I don't want you guys to think that I'm some expert on infectious disease epidemiology, but we are doing that directly with him. So he will orchestrate that once we get the data together. It's our own patients. We'll work together to get that out. But, you know, like everything else, we're not going to put out in shoddy fashion. It has to be, you know, reviewed, et cetera.
Sure.
But we're on a fast track with him on this.
Sure, brilliant. This question just coming from Jack. We'll probably come back to you, Dr. Berenson, so don't disappear. But there's a question that's coming from for Jack. We've been speaking about patients further along in their treatment, but what advice would you give to a newly diagnosed patient?
Well, I think all the tips I mentioned are appropriate for newly diagnosed as well. Realize that there are even clinical trials for newly diagnosed patients. As Dr. Berenson said, most patients these days are getting a combination called VRD, Velcade, Revlimid, and Dex, at least in the US. But there are trials out there now asking, is that the best induction treatment for newly diagnosed patients? Should we add an antibody, monoclonal antibody to those patients? Should we have more information regarding their high risk status and make changes to that initial treatment? So again, being your own best advocate, getting knowledgeable about what's out there, looking up clinical trials are all part of being newly diagnosed as well. So look early to get an expert myeloma specialist on your team.
Thanks, Jack. So we're kind of approaching the end of the webinar. So just in closing, and I'll try and do a very brief summation of about sort of three kind of key messages at the end. But just we've got Jack and Dr. Berenson left. So if I just go to Dr. Berenson first and say, look, just in summary, what is the single thing in myeloma that you're most hopeful about, most excited about, and what is the thing that keeps you awake at night about myeloma? And the same question to Jack.
Okay, well, I think I'm very hopeful because there's so many new things we can do. Our bag of tricks is unbelievable now. And you basically, and many patients don't run out of them. They may run out of wanting to do it anymore. It's a lot different than it was 20 years ago. I think the most frustrating thing is, for me, frankly, is the insurance companies and their ability to limit what I can do. That is the worst.
Yeah.
I'm very creative with how I treat myeloma, but insurance companies don't think that way. And it's really frustrating to have people in front of you with an 1114 translocation, and I know this is going to work, and the payers say, forget it, we're not paying for that. So that's probably the number one frustration right now.
Thanks, Dr. Berenson. Jack?
You know, having been diagnosed 26 years, I have gotten to meet so many of these doctors like Dr. Berenson and Dr. Fonseca. So what makes me so hopeful is the focus that they have on treating patients to the best of their ability and focusing on the patient. I'm just really thoroughly impressed by these myeloma specialists that are so knowledgeable and yet can talk down to earth at these to these patients in terms of what they should consider. Maybe what's most frustrating is that, at least in the US, I realize that a lot of patients aren't located in areas that where they can easily access these specialists, although maybe with virtual meetings like this, they're able to do better now than they were a year ago. But I always want to get at those patients that we don't see in our support group meetings
Sure.
that we would hope to see.
Sure. Brilliant. So last chance for questions, folks, if you've got any kind of questions coming in. And while you're doing that, I'll maybe just try and take 30 seconds to kind of summarize. So Dr. Fonseca talked a little bit about current treatment approaches in relapsed refractory multiple myeloma. And you can see quite clearly there's a plethora of options, but it's still difficult to choose the best option from the available options for the right patient. And thinking ahead about sequencing of current treatments is still a challenge. And while on one hand we're excited about the pipeline, I think there's still a job of work to do to optimize the use of current available therapies to maximize outcomes for patients, and also to be cognizant of some of the rate limiting factors. So we can have effective treatments, but if patients are unable to tolerate them because of side effects or because of accumulated burden of disease or toxicities from previous treatments, it's no good. So we've got to get that balance of kind of side effects right. From Jack's perspective, a really inspirational story. Had some very difficult decisions to make 25, 26 years ago. And thank goodness he made the right one and it worked out for him. But really emphasized the need for patients to be their advocate. And for those patients that can't be their own advocate for whatever reason, we've got to rally round and help these patients become their own advocate or be an advocate for them. But it's also important that physicians, clinicians, and nurses make it easier for patients and think about holistic needs assessment and very quickly understand the type of patient that's in front of them. And sort of balance the power out a little bit and help that patient get access to the information that they need. I think from Dr. Berenson's presentation, really hopeful, very exciting to see so many innovative things coming potentially through the pipeline. I think it's important to say that they won't all come through, and I think there's a job of work to do to try and pick the best horses to back to come through the system, so they come through in an efficient manner. And I think the most important thing is about specificity, to really target these new, I think, learn from the mistakes of the past in drug development and really start to focus in on that specificity and to design research that gets that specificity, that we get the data, we can get that through the regulatory hurdle. And importantly, to take pairs with us, because it is so frustrating for everybody to do all this work brilliantly and then to hit that final hurdle and not get access to these medicines in all patients. So I think there's a job of work to do for the community and for advocacy to make sure we're thinking ahead and working with pairs and making sure that the new treatments are implementable and transactable to the maximum number of patients. So that's my 60-second summary. I don't think there's any more questions. So thank you all very much for your participation today. Thank you for our esteemed faculty. I think they did brilliantly. Thank you to our audience for joining and for some really excellent questions. But for me, just a big thank you. And I wish you all to stay safe and stay well, and maybe we'll get a chance to meet you again. Thank you very much. Bye.